Okay. So good evening, everybody. So today we'll be starting with our first session of the series on neurosonology. Today's speaker is Dr. Pramod. He is an assistant professor at Ramaya College, and the moderator for today's session is Dr. Swetasri. She is an associate professor at NIMHANS. And in like transcranial Doppler being a non-invasive, repeatability is a very important thing in transcranial Doppler, and we can use it repeatedly. So today we will be discussing about the basics of ultrasound and the basics of neurovascular anatomy. I hope you will all like it at the end of the session, and lots of your doubts will be cleared. So over to you, Dr. Pramod. Kindly begin the session.
Thank you, sir. I thank you for giving me this opportunity. So, at the outset, I have a disclaimer to announce. Kindly do not use these content or the pictures or the video for copying anything. And I would like to especially thank my teachers at NIMANS as well as one of my teachers, Dr. Vincenzo Incangelo and Dr. Michael from Italy. And I also like to thank my students, Yamini and Ashushankar, for helping me make these videos and take pictures. I don't have any conflict of interest. With that, I would like to tell you today's class would be just based on the basics of neurovascular sonology. So the basic neurovascular anatomy and how do we check these neurovascular anatomy using an ultrasound. So this class will be majorly based on TCCD, and we'll start off with physics of of the ultrasound and slightly touch upon the probes and modes of ultrasound we use to see this vascular anatomy. We'll start off with extracranial vascular anatomy from the neck, and going above, we enter the intracranial compartment. We see the arterial as well as the venous neurovascular system, and we'll be ending with the velocities of these vascular structures which we see going forward. So with respect to physics, these are the equations we have all studied during college days, wherein the amplitude is the distance of a wavelength that travels in one cycle, and the number of such wavelengths happening in a second is called frequency, and the amplitude is the magnitude of the pressure change which creates it. So with that, we know that the velocity of the propagation speed is equal to the wavelength into frequency. I would like you to concentrate here that wavelength is inversely proportional to the frequency. Just remember that. So I'm telling you that because many of are already aware we have high frequency ultrasound probes and low frequency ultrasound probes. And how does this high frequency ultrasound probe make it better in resolution and greater attenuation and lesser penetration? That's because whenever an ultrasound waveform travels through a medium, its amplitude decreases, but its frequency remains constant. And the intensity of such a frequency in a medium decreases faster with high frequency probes than with a low frequency, which makes high frequency better in resolution and with a greater attenuation. And when the ultrasound beam enters any of the medium, it has an ability to give a clear picture that is called resolution. You have axial resolution and you have lateral resolution. In axial resolution, what I mean to say is you have 2 points. Let me just take out the pointer. Yeah. So you have 2 points, point A and point B. You can see that the wavelength is falling. Two different wavelengths are falling on point A and point B. So such a frequency will let you know that there are 2 points, point A and point B. Whereas the other transducer, you can see a single wavelength or a lower frequency. You'll be traversing across the point A and point B, and you won't be able to see these 2 points as two different points. You'll see them as a single point. That is called axial resolution. Similarly, the lateral resolution, you'll be able to recognize two different points in the transverse axis as a separate points. If the beam is inside these 2 points, you will recognize these 2 points as separate. If these 2 points are within the beam of the ultrasound, then you will recognize them as a single point rather than two different points. This is lateral resolution. And focus is a region where you want to see an object inside an ultrasound image. So this narrows when the beam is converging, and it can diverge when the rim is diverging. So remember, this beyond a focal point will always diverge. That will cause a less lateral resolution. So you won't be able to see points further away once the beyond the focus point, because the lateral resolution is less. So this is what I mean to say. So focusing is, this is a synchronous beam coming in straight on into a tissue, and it goes straight. This is a focused beam wherein everything is coming up and it's meeting at a point called focus point, and beyond this it again diverges. So there are variations which we can bring in when you are using an ultrasound. Let's say your point of interest is somewhere here, but you don't want your beam to go straight. So you can make your beam to go down. So that is called beam steering. Suppose the same way you can steer the focus. Your focus of interest is not here, somewhere here. So you can steer your focusing so that you get the point of interest into your focus. So, as most of you will be aware about the Doppler ultrasound and the how the velocities are calculated, it's basically based on this formula which is mentioned here. So, how do we how does the machine do this? So, it's basically emits two frequency, a frequency called F and F star. So, F star is the frequency which is reflected back from the tissue inside a body. So, what does it do? It amplifies the reflected frequency, and then the demodulator subtracts it. So once the demodulator subtracts the received frequency from that of the parent frequency, it straight away sends it to a speaker where you hear the sound tush 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 tush. So that's the one, what is called the Doppler difference in the frequencies. And this frequency is again sent to a discriminator to discriminate whether a frequency which you have received tells you whether it is an arterial or a venous, or whether it is coming towards the probe or away from the probe. So that discrimination is made based on the discrimination of the flow direction. So that will discriminate, if something is towards the probe, it appears red; something is away from the probe, it appears blue. And these frequencies are further put into Fourier analysis that gives you a Doppler spectral graph. So in this equation, as you can see, cosine of theta or cosine angle is the most important one, which helps you to estimate the velocity of the blood in the system. So when we say the angle, so you can see as the angle increases from 0, 10, 20, 30, 40, and 90. So this is the point of interest of the vessel, and this is the blood which is going into the vessel. So if your vessel and your angle is at the same parallel to each other, the angle between them is 0, and you get a 0 error, and you get a perfect Doppler shift and a perfect graph. The same thing does not happen as the angle increases, your error increases. So you might want to keep the error as less as possible. So it is always advisable to make an angle correction whenever feasible. So it is said that the extracranial compartment wherein you scan for carotid Dopplers or vertebral Dopplers, it is advisable that you make the angle correction. And there are different school of thoughts when we do the angle correction for intracerebral vasculature. Certain authors say that to keep it uniform, you need not do the angle correction. Certain authors do say that you can still make an angle correction. So what is a continuous wave and a pulse wave Doppler? So most of our Dopplers are pulse wave Dopplers, wherein in the continuous wave, there are two things, the transmitter and receiver. They both are different. Whereas in a power wave Doppler, it's the same thing, wherein it emits and it receives. The both crystals are in the same compartment here, in the pulse wave Doppler. Speaking of probes, the most commonly used probes for TCCD is the phased array probe, and the vascular anatomy for the neck, we use a linear probe. So as we are aware, the linear probe is a high frequency probe, and phased array probe is a low frequency probe. But it's between, like you have a curvilinear probe, it's lower frequency than the phased array probe. So this phased array probe frequency generally fall between your curvilinear and a linear probe. So this makes it a better probe for most of the things, because it has a features of a lower frequency to penetrate deeper, and also a bit of features of the higher frequency to delineate more clearer. So this makes it a best probe for your transcranial color coded duplex Doppler, TCCD. So when we speak of modes, we always start with a beam mode, that is the brightness mode. That's the basic mode we start off scanning with. So once we do a beam mode scan, we do a color scan. So you just put a color window and see what structures beneath give which color. So anything which is blue is moving away from your probe, anything which is red is moving towards your probe. And then we put a pulse wave Doppler and at the center of the vessel and measure the velocities. This is a spectral Doppler spectrum you get once you put the pulse wave Doppler. This is called a power window or a power mode, wherein it delineates the vessel wall better than your color, because going forward we'll discuss about what does the power mode exactly mean. So in B mode, it's more of a basic mode wherein you need to use it whenever you're looking for, let's say, an arterial wall or a lumen or surrounding tissues, because you want a clarity about what exactly is happening into the lumen or outside the lumen or on the wall. And you would like to use this whenever you're measuring any thickness or plaque or clots or any intimal flaps. So as you can see in these two images, you can see the vessel wall so clearly in this, and also you can see a thyroid tissue here on this one and the vascular structures in this one. So steering of B mode, what do you mean by steering? It's just like a steering wheel. Like when you want to go right, you turn right. When you want to go left, you turn left. Here, you just want to steer your beam to see if there are any. Let's say you have a plaque here, which is not been picked up with a beam which is perpendicular to the plaque. So you need to steer your beam towards the focus of interest so that you align it in the line of the ultrasound beam so that you can pick it up. So most of the steering functions are available in most of the newer versions, so that when you want a non-perpendicular study, you can use it. This is one more example. You can just see the arterial wall here, so that if you steer it left and right, the changes which you can see how it changes with steering to left, steering to right, and keeping it neutral. So once you are done with B mode, you put a color box. The color box will basically put a color into the tissues or the vessels, or and tell you based on the Doppler shift whether the frequencies which are matching are coming towards you or going away from you. It's just the expression of the medium of the flow rate in the color mode. So again, we can use this stirring in the color mode. So if you feel the flow is towards this side, you can stir it this side. If you think the flow is on this side, you can stir the color mode onto the opposite side. So this is an example of a color stirring wherein you see the flow is from the common carotid going into the internal carotid artery here. So up till here, the flow might be towards the probe. From here, it's going away from the probe. So you need to steer the color box towards the flow as well, so as to get a perfect image. So you can see that here the flow is away from the probe and you steer the color box away from it. So you won't get a perfect picture to measure the velocities, nor will you be able to understand what exactly is happening at this point. So you need to keep that in mind as well. So going ahead with further modes, just basic parameters of instrumentation depth, sample volume, PRF, theta angle, and Doppler gain, and wall filters. How do we use it? What are these things? So this sample gate is just the sample. This is the sample gate and the sample volume. So you need to keep it at the center of the vessel, and the cursors of angle should always be parallel to the vessel and in the direction of the flow. This gives a Doppler spectrum, which is absolutely normal in this. This is a common carotid artery. Whereas if you put a sample volume too small, then it hampers your spectral Doppler spectrum. If you keep it too wide, it takes additional vibrations, additional frequencies as well, which will give you a Doppler like this. So which is incorrect. So you always need to place it within the appropriate margins and also keep the angle appropriately. This is the most important thing of today's topic with respect to venous Doppler. So what is PRF and what is aliasing phenomenon? So PRF is nothing but when an ultrasound generates pulses, it usually consists of 2 to 3 cycles of the same frequency, and the number of such pulses transmitted in a single second is called pulse wave pulse repetition frequency. It is measured in kilohertz. So this PRF is closely related to insunation depth. So suppose, let's say you have something deep enough and you need to visualize. You need to reduce the PRF so that you can insunate it better. So we'll take an example. So here you can see this is an optimal PRF to visualize this artery. So once you decrease the PRF, you will start picking up signals from across, and you will also see aliasing. That is, there is some mixture of red, blue, yellow, and other colors, which will look like turbulence. So that is called aliasing. Whereas when you reduce it further, your this aliasing just started to appear. So the same thing here. What happens? Let's say if you put two less of a PRF and then you measure the spectral Doppler, you put up a pulse wave Doppler and you measure it. So this gives you an aliasing effect, and also it broadens the spectrum. So you should always know when exactly is optimal and what exactly is abnormal, so that you need not misdiagnose things. So there is something called as power in each probe. When we use the TCCD, keep in mind that uh, it has to compile with the FT and European guidelines to reduce the power whenever you're using an orbital window. It's basically just a force with which the piezoelectric elements vibrate. So you don't want them to vibrate more when you're keeping it on an eyeball, or you're keeping it on a patient who has undergone craniotomy, because it does have a mechanical effect which would probably lead to increase in temperature or cavitation. So always follow a Lara criteria, where is as low as acceptable whenever possible. Okay. And then in the power mode, as I was saying, it does not depend on the alpha angle, which makes it a better mode to visualize the continuity of a vessel wall. And it gives you just like an image of an angiograph, wherein you do a DSA or an MR angio or a CT angio. It gives such a sort of picture whenever you put on the power mode. So with that, we will slightly go further to see how we can adjust the gain. So gain is nothing but we just increase the brightness. So how does it increase the brightness? It just amplifies the reflected frequency or reflected waves from the ultrasound beam. So if it increases that, when you increase the gain, so this is on top, you see it's the power adjustment. When you go from 0.2 to 1 mechanical index, the power, this is how the power index, the power increase in power looks. Whereas when you check the gain adjustment, you just increase the brightness in the deeper region. So you can selectively increase the brightness of a region of interest. You can see there will be plenty of knobs this way. You can adjust with them. If you want something to be visualized at the deeper end, you can just move these up and down. And the gain can not only be done in beam mode, keep in mind it can also be done in color mode. So the color gain can also be increased, and it can also be increased in a Doppler mode. So once you put a pulse wave Doppler, you can increase the Doppler gain as well. So coming to filters, filter is something which you want to use when you want to visualize. When you don't want to use when you want to visualize something which is very small, or which has got very small velocities. Let's say for an example, vein. So here you can see an arterial waveform and a venous waveform which are overlapped. The moment I put in the filter or increase the filter, the waveforms of the venous flow are no more to be seen. So if I increase the filter further, it will again reduce my Doppler spectrum. So common artifacts we see is shadowing, which is either from a hyperechoic or an opaque shadow of a bone, which is a transverse process here in the vertebral. And similarly, you can see a reverberating effect, which is sort of a reflection of the sheaths or the arterial wall itself. This can also be seen whenever you do any regional blocks, wherein you see multiple needles when you're passing, or when you're passing a central venous catheter. The mirroring is just nothing but you see a mirror image of an actual image. Here you can see MC and ACI getting mirrored one behind the other. With that, we'll start off with the extracranial anatomy. So we have a carotid protocol and a vertebral protocol in extracranial anatomy. So the basics thing is start with a beam mode, start scanning the neck as shown here in the video as well. And once you start doing that, you go ascend up cranially. So you ascend up cranially to look for the vessels, that is the common carotid and the internal carotid and external carotid. So once you do an axial plane, go for a longitudinal plane, the same thing again, start from the neck, ascend upwards. So you can just see the direction of the probes tilting backwards towards the spine and forward towards the opposite ICA, which will help you delineate the ICA and ECA. So this is once you go for up and tilted backwards, you will see the ICA, this internal carotid artery, and once you move it away, you see the external carotid artery. And then once you do that, you put the color window and then the Doppler window. The Doppler window will give you the spectrum. Make sure that it's at the center of the vessel and also measure the uh, farthest velocity as possible, that is towards the nape of the neck. And then you put the color window in the external and internal. So whenever you put a probe on the external carotid artery, you can do a temporal tap, which would be transmitted into the external carotid and which will give a fluctuation. So for the vertebral artery, you just keep it across. Again, the common carotid artery is the landmark. You scan for the common carotid artery, just tilt it laterally towards the spine to see the vertebral artery. So you will see the vertebral arteries as shown in this video. We'll just discuss them as we go forward as well. So you try to trace the artery from starting from the subclavian higher up, and this would be a different positions of V0, V1, V2, and V3 and V4. V4 is generally intracranial. V3 is behind the ear at your mastoid, but the way to hold the probe is the one I have shown in the image here. So this is basically the neurovascular anatomy we are going to discuss, starting with the subclavian, going upwards, the extracranials, and then the intracranials. So with the extracranial, we have the common carotid, external carotid, and internal carotid. So before we have an internal carotid, we have a bulb to look at. So the most commonly we get the ICA placed laterally to the ECA. But how do we differentiate the ICA and ECA when we scan? So when we scan for an common carotid, and then when we see two vessels coming this way, and if at all you see any of the branching, that is most commonly your ECA. The first branch of ECA is from your superior thyroid artery. So this is your superior thyroid artery in the ultrasound as well. So this is the position you need to keep the ultrasound probe to scan in the transverse way and in the longitudinal way. The pointer remains laterally here and cranially on this side. And then once we done with the beam mode, you put on a color mode and see what are the vessels you see. Something red is towards the probe, something blue is away from the probe. This is common carotid, and you put a pulse wave Doppler and measure the Doppler spectrum. And once you are in the common carotid, you ascend up and tilt your probe from the origin towards laterally, pointing towards the spine. That gives you your intracranial artery. Once you turn it medially, it gives you extracranial artery. So how do you differentiate apart from the probe position? And also I mentioned the tapping of superficial temporal artery. The other thing is it has a high pulsatility in the extracranial external carotid artery, whereas in internal carotid artery the pulsatility is low and you have low resistance vessel. So you always see a good diastolic flow in these things. And apart from the branches, you can also tap, as I already mentioned. So this will show you the Doppler spectrum of the internal carotid artery. This is from the external carotid artery. This is from the thyroid artery. So when you tap the thyroid gland and put your probe on the thyroid artery, it gives you a fluctuation. And here, if you put it on this is an external carotid, which will, when you tap on the superficial temporal, it gives you the fluctuations. So to give you an outline of the carotid system, the internal carotid will have a good diastolic flow, whereas external carotid is more of a triphasic flow. When you combine these two, you get more of a common carotid artery flow. So with respect to vertebral, you have different segments which is arising from the subclavians on both sides, V0 to V4. V1 is the one segment which is below the just arising from the subclavian going up till the C6 transverse process. And inside the transverse process, we have the V2 segments. Outside the C2, between the C1 and C2, you have it arching and entering the skull. That is your V3. The V4 segment is intracranial part, which we'll see in the later slides. So these are the ones which you can you visualize using the ultrasound. We can visualize V1, we can visualize V2 and V3 and V4. But in the neck, only V3. We won't be able to visualize V4 with the linear probe. The probe needs to be placed this way, and then you will see this is the subclavian, this is the triphasic flow in the subclavian on the right, and this is on the left. And as I said, scan for the common carotid, tilt it laterally onto the spine. You will see the spinous processes, the transverse processes of the C6 and C3 and C4 and so forth. And you see the vessel in between these two transverse processes. You put your then color window and then the power pulse wave Doppler, and you measure the velocities. Similarly, this is the V3 component, which is behind the mastoid. This is how you place the ultrasound probe, and it's shown here as well. And this is how you see a segment which is going in and coming out. So this is coming in from below and going in into C1. So this is your C1 and C2. So you need to place the angle appropriately when you're measuring the velocities here and you're measuring the velocities here. So this is a rough outline of the entire vertebral thing from arising from C6 going up to C3. So this is the spectrum you get once you start measuring the velocities from C6 to C3. This is all the V2 component of the vertebral. With that, we'll go into the intracranial part, which has an arterial protocol and venous protocol. So again, the same modes always start off with the B mode, and then put a color window, and then a Doppler, and then a power mode. So the modes remain the same. It's just the structures change. So here we have the most important one is the temporal window, also called the mesencephalic plane, or a midbrain window, you can say. So this is the transverse plane where you axial plane when you are looking at. This is how you look, and these are the probe placements. So your probe is placed just over the earlobe, pointing towards the pointer has to be pointing towards the external canthus of the eye. So that's it. That's how you place the probe, and then you start tilting the probe upwards and downwards, going to see different structures. So you see this plane, and if you want to tilt it, see something in this plane, you just need to tilt it above and below. So the other plane is the coronal plane. That is same as when you place it in the horizontal plane. Just tilt it perpendicularly 90-degree. That makes it coronal plane. So this is an axial plane and this is a coronal plane. So these are the three images which are the most commonly used for transcranial color-coded duplex Doppler. So wherein the pointer is pointing towards the eyeball, the lateral canthus. So you tilt it above and below. So similarly, you see structures here, starting with the butterfly sign, what we call the midbrain here, and you go above to see the third ventricles and the lateral ventricles, and you go below to see the medulla. So this is your axial plane, and this is the coronal plane. So to start off with coronal plane, first always start with the axial plane and then tilt your probe perpendicularly, so that you don't miss out where exactly your axial plane is. It makes things easier. So always start off with an axial plane. So this is how you see from anterior to posterior. You can see the lateral horns here in this patient as you tilt forward and backward. And this is a foraminal view, that is the foramen magnum. Through the foramen magnum, we visualize the structures at the base of the skull. So here you need to place the probe here, pointing towards the glabella of the patient from behind. So once we do that, after the B mode, as I said, the next thing is color mode. So put on a color mode on the B mode and start visualizing the vessels. So always remember the depth of the vessel and the color of the vessel. So you see something red at this depth, which is coming towards the probe, is always a MCA, and ACA you can see the A1 will be away from the probe. So if you tilt the probe downwards, you will see that the ACA and MCA are arising from your ICA, the internal carotid. So you have plenty of branches of the internal carotid, and also you have the siphon. So you can see the siphon here, which is red and blue. And as you come ascend above, you see the MCA and the ACA on this part. So once you see that, beat any vessel, what next is the Doppler. So you put the Doppler and angulate it appropriately. The gate can be kept wide in the intracranial compartment, unlike that of an extracranial compartment, where you need to pick up a good amount of spectral Doppler in these intracranial. As the intracranial vessels are small, you can keep it a bit wide. So this is the spectrum you get once you start doing the pulse wave Doppler. Once you put the pulse wave Doppler, so wherein you can measure it. Most of the machines give you an automated peak systolic and end diastolic. In fact, you can do it yourself. You can just trace the spectral Doppler. So how do we do it? I'll just show you. So always start the envelope from the systolic. I'm sorry. So you start it from here and you ascend up, and then you go down and you stop here. You do not take it below. That is wrong. So don't take it below, because you always have a diastolic flow. If you get your diastolic flow to 0, then that it won't calculate it appropriately. So once this envelope is encircled this way, the machine automatically calculates your peak systolic and diastolic. Sometimes you also get time average velocities, which is means velocity. And with these, the other values are derived. You have resistive index, you have pulsatility index, and so on and so forth. These are all derived from these velocities itself. So when we are thinking of the intracranial system, everything arises from two systems, that is your internal carotid and the vertebral basilar. So internal carotid, you have different vessels. The internal carotid, you have different parts of internal carotid. That is your pars cervicalis, petrous part, cavernous sinus part, and cistern part. So one second, yeah, let me take a pointer again. So how do we see these structures? So always go from an axial plane where you see MCA. Once you see MCA, tilt it downwards. So this is your petrous part, wherein you see the ICA coming between your petrous bone. This is in the axial plane. Once you tilt it in coronal plane, this is how it looks. In coronal plane, you can see it's coming in the canal here, and it ascends up. That is your internal carotid into the canal. So once you do that, you put the next steps remain the same. Put a color window and the power Doppler, angulate it, measure the velocity. So one more way of measuring, confirming what you're seeing is exactly the ICA or something else. So this is the carotid siphon. As we know that ophthalmic artery arises from the carotid siphon. So you do an axial plane, get an MCA window, tilt it downwards, and then you see your carotid siphon this way, and there is something arising from the carotid siphon. So you put your pulse wave Doppler here and just gently tap on the eyeball. So that gives you a pulsatility of this that will confirm that this was the carotid siphon behind this. So with that, once the ICA is reached on top, you have two things: MCA, the most important one, the ACA. So MCA is always towards the probe, so it appears red in color. So you have different branches. You have horizontal branch, insular branch, opercular branch, and cortical branch. Let's see how do we see this. So most of the times you have this Sylvian cistern here, in which we see the MCA lying. So you once you put the color window, you put the pulse wave Doppler, and you measure the pulse wave or the velocities with the spectral Doppler. So we need to put an angulation appropriately to measure it as well. Next is your branching of M1. That is, you keep an axial plane, tilt it into a coronal plane. You will see the branches of the MCA into M1 and M2, or the M2 branches. This is your ICA coming in, turning into ACA and MCA. So these are the terminal branches, I would say, mostly difficult to insonate. So this is a higher up plane. So you have your mesencephalic plane and you tilt it upwards. So this goes into somewhere it's looking in somewhere into the ventricles. So you see a ventricle here, something lateral to the ventricle is more of your insular and opercular branches. So here, since it's a tortuous artery, you can see the flows going away and towards. So that's how you see these branches. This is a beautiful image of both the MCA and the PCA. We'll look at this later again, the PCA. The ACA segments, you have the pre-communicating segment, that is A1, A2, A3, and A4. So once you know that this is MCA, the first thing after MCA would be your ACA. So the flow of ACA is always away from the probe, so that appears blue. So you put your pulse wave Doppler and measure the velocity, you get an inverted spectrum this way. Sometimes you will also be able to see the A1 arising. I mean, you will be seeing a hypoplastic A1 on the opposite side. Whatever the colors you get on this side, let's say the MCA is red, the opposite MCA would be blue. The same side ACA is blue, the opposite would be red. So that's because it's towards the probe and this is away from the probe. And this is how you see for ACA. And then the terminal branches of the ACA, you same thing, you tilt from the mesencephalic plane, tilt it above. Again, you see the ventricles here. But remind you, this is medial to the ventricle. Last time we saw was the lateral to the ventricles, you see the MCA branches. Whereas medial to the ventricle, you see the terminal ACA branches. Coming to vertebral basilar system, this is from the posterior aspect. I put this upside down because this is how you see when you see an ultrasound in the foraminal view, that is behind the below the occiput, pointing towards the glabella. So this is the foramen magnum which you need to target when you're placing the probe. There are two windows. So this is the higher pontine, this is the lower pontine window. So when you see this window, you'll be able to delineate these are the clivus, this is the foramen magnum, and you have the medulla inside. So this is how you insunate this window. So once you insunate this window, let's see what all you can see. Suppose let's say you're insunating this window and suddenly you see this. So what happens? Your pointer, your angulation might have gone horizontal. So you see what you're seeing now is the spinal cord and the spinous processes and the spine here. This is not the foramen magnum. So you need to angulate it higher up, pointing towards the glabella of the patient. So as you see here, the first two branches which we will be able to see from below upwards is your vertebrals ascending up, joining to become basilar, and basilar giving branching to PCA. So let's see what are all the branches of these vertebrals which you will be able to pick up on the ultrasound. So these are the two vertebrals coming in beautifully and forming a basilar artery here. Before that, you see on this side there is something arising from here which is looping around. That is your pica. So whenever you see something moving away from your probe, when you keep a probe in the occiput, so your vertebrals are carrying the blood and ascending upwards. So it's going away from the probe. So you see it as a blue color. That is your vertebrals on both the sides. This is more or less called a Y sign. And once it combines to form basilar, even the basilar is carrying the blood away from you, so you see it as blue in color. Whereas the pica is carrying the blood and it's just looping around up and down here. So that's why you see something red, because sometimes it comes towards the probe. So this is your pica. So once you know what you're visualizing at, you put the pulse wave Doppler to measure the velocities. So this is on the left side and this is on the right side. Sometimes, most of the times, it is one side would be dominant. So that's why you see a variation in the Doppler spectrum with respect to vertebral arteries. Whereas this is the pica, which is flowing towards the probe. So you have a positive spectrum. Similarly, you have your vertebrals joining to form basilar. At a different level, you can measure the velocities. Put a pulse wave Doppler, you get the velocities. Again, here the basilar is carrying blood towards the brain, and your probe is looking at it, so it's going away. You get a inverted spectrum for basilar as well. So this is another way of looking at basilar. This is from an axial plane. This is from somewhat coronal plane, semi-coronal, I would say. So you can see the basilar segment. This is 19 millimeter here. This is more or less 18 millimeter. And these are the PCAs coming out of basilar. So once the basilar is formed, the basilar gives branches to ICA. So again here, something positive, something which is red in color, that is getting blood towards the probe, is ICA. Again, but that's because of the branching and because of the orientation of the ICA, you see it as red. So once we see this, what we do, you just put the power Doppler and then measure the velocities. So to give you a gist of what we look at when we put the probe behind, so through the foraminal view, to start off with, we have the first one is your vertebral on the left. The second would be somewhere the origin of basilar. This is again the basilar. Something near to the vertebral showing a positive deflection or towards the probe is your pica. So something at the mid region, or let's say at the terminal region. Mid region would be once the basilar is formed, something arising from the basilar would be ica. So once you go at the terminal part of the basilar, that is towards the terminal part of the basilar, what you see is superior cerebellar and PCA, posterior cerebral. So these are the two spectrums of your posterior cerebral and superior cerebellar. So once you do that, you can also visualize these in the coronal view. So with that, we'll enter the PCA segment. Again, start with the axial plane, visualize the MCA, visualize the points. Just in front of the points, you have your PCA. So this is your PCA on this side and PCA on the opposite side. So if you just slightly tilt it below, so what you see, a small vessel here which is pointing out with the white arrow, that is your superior cerebellar, because once the superior cerebellar arises, after that your basilar gives branches to posterior cerebral. So that is how you just have to visualize the anatomy in your brain and see what are the signals picking up. Is it towards the probe, away from the probe, depth? And then you put a pulse wave Doppler to assess the velocity so that you can confirm. So with that, we'll end with the PCA. So PCA, you have different branches, but the most easily ones which can be delineated is P1 and P2. So these are the branches which are arising from P1 and P2. That is anterior temporal, occipitotemporal, parieto-occipital, and calcarine. These are very difficult to insonate. We'll see what are the easy ones to insonate. So this is your midbrain. This is again your axial window. You see the MCA. Just behind the MCA, you see this. In front of this, you see the PCA. So this is your P1. P1 is always towards the probe, so it appears red. P2 is away from the probe, it appears blue. So next thing you do is put the spectral Doppler and measure the velocities. Similarly, you can see the branches of the PCA, that is your anterior temporal. This is your distal PCA, and this is your occipitotemporal. This is again to show you that common anomaly, or anomaly where you can see that your PCA is arising from your ICA. This is called fetal type of PCA in this. So here you can see a system which connects your anterior and posterior, that is your PCOM. So this is your PCOM here. So with that, we have covered the intracranial compartment, the major arterial system. So we'll enter into the venous system. Let's see what are we need to know regarding the venous system. Believe me, venous system is difficult to insonate. Second thing, you can't insonate all the veins. There are specific veins you can see, and you cannot just insonate a vein just like an MCA or an ACA. It's always a correlation of these veins with respect to arterial system, and that is how you insonate these vessels. So we are aware that there is a deep vasculature, which deep venous system, and the superficial venous drainage, which are connected. So majorly the deep venous system, we can insonate the deep middle cerebral vein, and this is the deep middle cerebral vein, and this is the basal vein of Rosenthal, and this is the internal cerebral vein, which is again difficult to insonate, but you can insonate the great vein of Galen. Again, this is in the transverse view, the veins which you can insonate. Here you can see this is the terminal part of superior sagittal sinus. This is the straight sinus. This is the vein of Galen, which you can insonate. So for the insonation, you have particular windows. See, most of the veins again can be insonated to the temporal window, that is your deep middle cerebral vein, spinoparietal sinus vein, and basal vein of Rosenthal. So when we speak of deep middle cerebral vein, this can be insonated at M1, M2 junction, or at these segments. So we know how to insonate M1 and M2. So you just have to visualize M1 and M2, and I'll tell you what else to do to visualize the deep middle cerebral vein. So spinopalatine sinus, you can visualize at the medial border, small wing at the medial head of the superior petrosal sinus. Basal vein of Rosenthal, as the deep middle cerebral vein goes backwards, communicates, it meets near the PCA. So these are the landmarks. So you have your MCA as a landmark for deep middle cerebral vein, and you have a PCA as a landmark for basal vein of Rosenthal. So once it goes behind basin vein of Rosenthal, you have the great vein of Galen, and these are the sinuses: the straight sinus which descends downwards, and the transverse sinus, and also superior petrosal sinus, which is more of in the posterior fossa. And also you can insunate these two can be these three can be insunated through the temporal window. So the occipital window, that is the foraminal window, you can insunate inferior petrosal sinus and the transverse sinus. So with that, I think I'm clear about which veins you can insunate and which are all the windows to use to insunate these veins. Once you have decided to insunate a vein, so that is after you visualize the mesencephalic plane, let's say, and after you have visualized the MCA, then you troubleshoot your ultrasound to these things. So whenever you almost use the same probe, that is phase array probe, check the low pass filter, check whether it is on or off. It's better to keep it on, or at the least or minimize it, so that it would not cut off the low velocities from the venous system. And then the PRF, what I was telling you about, you need to reduce the PRF as low as 0.5 kilohertz or even lower to get a good gain or get a clear image. So once you do that, you can play with the color gain, either increase it or reduce it gradually to a point where you see a noise appears. What do I mean by noise? The entire screen goes either red or blue. That is called noise. So as and when the noise starts appearing, you stop. So I said the temporal view, axial plane, the MCAs I can see. And once I see the MCA, I put all the settings which I just told you. And just this is M1, this is your M2. So behind this is your deep middle cerebral vein. So once I see all the veins would be going away from the probe, so it would be blue here. Deep middle vein, it will carries the blood away from the probe. So once you think that it is deep middle cerebral vein, to confirm it, put up pulse wave Doppler, and this is the velocity of a vein. Whereas if you can remember the velocities and the pulse wave Doppler of an arterial waveform, how does it exactly look? So that will differentiate. If you're still not sure, you can just pull the cursor onto the MCA and visualize the MCA. So you'll be able to differentiate it better, whether it is a vein or an artery. Similarly, once the deep middle cerebral vein is over, again, this is your MCA. Something goes behind at your PCA. So that is your basal vein of Rosenthal. So again, once you're in this window, make the settings for the venous view and then put a pulse wave Doppler. So here in this image, you can see there is an overlap. So suppose, let's say if I put on the filter, I would have missed this spectrum of the vein, and I would have just seen the arterial waveform. So that is what is important. So you need to switch these filters when you are using to visualize the venous system. So this is again your great vein of Galen. So where do you see this? So again, the axial plane. So once you're scanning in the axial plane, slightly tilted upwards, you see the pineal gland, which is slightly hyperechoic. Just behind the pineal gland, you see something moving away from the probe, which is blue in color. You put your pulse wave Doppler there, you get the waveform of a vein. So that confirms that that is the great vein of Galen. This is a difficult one. So neither you have an axial plane or a coronal plane to visualize this. So what I do, I start off with an MCA in an axial plane and I turn it into coronal, but I won't turn it completely. It's a semi-coronal plane. So all that you need to do is imagine that you're looking at the straight sinus and then tilt your probe appropriately. This is the tentorium. So generally when you see the tentoriums, cerebelli, that's where you have your straight sinus descending downwards. So as I said, it descends downwards, it carries blood away from you. So the probe is here, you see something moving away from you is blue in color. You put the pulse wave Doppler and you see the velocities again. With that, we'll see how do we see the transverse sinus. This is the easiest one to visualize, but you need to be very sure whether it is a transverse sinus or not. So how do we do that? So you start with the mesencephalic plane. Again, I can see my MCA and PCAs. You just increase the depth so that you can see the opposite table, opposite cortex. So once you see the opposite cortex, this is where you need to insunate your transverse sinus. So always, let's say you want to insunate the left transverse sinus, you can insunate through your right. So it is a contralateral approach. If you want to do it onto your right, you do it, you put the probe onto your left. So how do I confirm it whether what I'm looking is a transverse sinus or something else? So when I'm looking at my left transverse sinus from the right, I press my right internal jugular vein. So if I press my right internal jugular vein, the left transverse sinus will augment the drainage of my brain into the left jugular. So whenever I press on the opposite side, on this side, you can see the pulse wave Doppler of the transverse sinus getting augmented. Suppose, let's say, I'm looking at the left transverse sinus from the right side and press my left internal jugular vein. You see there is a dampening or a cutoff. So that's how you see the transverse sinus, and that's how you delineate. This is again the terminal part of superior sagittal sinus. Again, the axial plane, and then you just have to visualize where exactly it is your superior sagittal sinus. It's just above from your tentorium cerebelli. So you need to tilt it semi-coronally and just manipulate it up and down so that you see something red. So why is it red? So this might be at a confluence, or the blood is flowing towards the probe in this direction. So you see here, once you put the pulse wave Doppler, you see the spectrum of a venous spectrum. This is how you see the terminal part of your superior sagittal sinus. These are the difficult ones to visualize. The superior petrosal sinus, which is more or less you can see at the lesser wing of sphenoid. So if you remember this, you start off with an MCA in the axial plane and you tilt downwards or upwards to visualize the lesser wing of sphenoid. So once you will visualize the lesser wing of sphenoid, put a color window and you would be visualizing this. So once you visualize this, you put a pulse wave Doppler to visualize the spectrum of the superior petrosal sinus. If you remember correctly, when we started off with the venous system, I said there is deep middle cerebral vein at the M1 and M2. So there is something in front of M1 and M2 now. What is that? So that is your, again, superior petrosal sinus. So this is another way of insunating the superior petrosal sinus. So you put your probe anterior to the M1 and M2, wherein you see a blue dot which is carrying blood away from you, away from the probe. That appears to be spectrum for superior petrosal sinus. Once you get it behind M1 and M2 and you see something which is carrying blood away from you that is blue in color, and put the spectral diaphragm and you see this, that is your deep middle cerebral vein. So the last one is your inferior petrosal sinus. This is again a difficult one to visualize. This is more of done through, again, foraminal view, that is behind at the occiput pointed towards the glabella. So here you can see it is the petroclavial groove wherein it descends down to join the cavernous sinus. So here you see this is your vertebrals. So this is your inferior petrosal sinus. So you put the power Doppler window and measure the velocities. So these are the basic velocities of the arterial system. So why I have mentioned only the arterial system here? The venous system, the velocities do change person to person, and there is no constant cutoff or a range for the venous system more often. It's more of an arterial system which has a good range, which is being described in the literature. So these are the reliable velocities. So you see the common carotid has a highest velocity. Getting down to internal carotid, it reduces. The external carotid has a slightly higher velocity, but look at the diastolic flows. The diastolic flows are quite high in your internal carotid. That's because of the low resistance. Similarly, you can see the MCA velocity as it goes is high, and then the ACA velocity reduces to 95 and PCA to 70, and the basilar, which arises from the vertebral, has a higher velocity of 60, and vertebrals have 50. So this is the systolic and the diastolic velocity. So you can just refer this for the velocities, and it's not the velocities that will trouble you when you're doing the ultrasound. So it's majorly the insulation window. So you don't get a good insulation window. It's very difficult to get it in 10% of the patients. I do understand. And keep these things in mind. So always start with a landmark. For a landmark in the external carotid system, it's the carotid artery, and then you go ascend up till the probes. So that acts as a landmark. The common carotid artery acts as a landmark to you. Whereas in the intracranial system, it's the MCA and the mesencephalic plane which acts as a landmark. So once you reach your landmark, so you have reached the landmark to visualize the other structures. So you need to know what is the insulation depth you are looking at, what is the direction of the flow of a vessel you are looking at. Is it towards you or is it away from you? Once you know the direction of the flow and once you know what depth it's been insulated, you'll be able to make a decision that this is an MCA, this is an ACA, this is a terminal ICA, this is a bifurcation of ICA and MCA. And then you put a pulse wave Doppler, you measure the velocities. So when you're measuring the velocities, always try to keep the angle towards the flow and parallel to the vessel. And you try to trace the vessel proximally and distally as much as possible to make sure that the vessel you're visualizing is the vessel of your interest. And once you make the Doppler velocity, you can still do the angle correction once the velocities have been measured as well. So with that, I hope I have given you a clear, a rough picture of how exactly to visualize all the vessels of the intracranial and extracranial compartment, which are of importance for a neurointensivist point of view. So I hear, I do forget things. I see, I remember. I do, I understand. So I would request you to do this on your patients on day-to-day basis so that you get better at it, because the TCCD has a slightly higher learning curve when it comes to TCD. And I would like to thank you all and also request you to subscribe to NCSI channel and enjoy learning. Thank you.
Thank you, Dr. Pramod. That was an excellent and extensive presentation on the neurovascular anatomy, and especially
Thank
the
you.
venous system. Yeah, it was really good. So, because it's a point of care tool which can easily be done bedside and repeatedly, it can be used not only to diagnose but also probably to assess the efficacy of our change, especially in the neurointensive care units. So now let us move on to the questions, please. Dr. Pramod, there is a question by Dr. Bharat which says, what is the advantage of TCCD over TCD? Which is better?
I would say
Would you
it
like
all
to answer?
depends on. Yes, ma'am. I would say, see what you're using the TCD and TCCD for. If it solves your purpose, well and good. That's the best modality to start off with. So there are drawbacks of TCD and there are drawbacks of TCCD as well. So TCD is more of, you presume that your angle of inclination is less than 30 degrees and you use TCCD to insulate most of the vessels. And sometimes you don't know whether what you have measured is of a particular interest for you or not. You presume it that that is the one. Whereas TCCD gives you an upper hand to make the decision whether what you have measured is the entity which you wanted to measure. Let's say an MCA. So you wanted to measure a velocities at M2 segment. So in TCD, I feel you will end up measuring the MCA velocity. You don't exactly know whether it is an M1 segment or an M2 segment. Here, I can definitively say that no, I have measured it from an M2 segment. I can see an M2 segment on a TCCD, whereas I cannot see any segmentation or branching on. It's difficult to say whether it is a branch of it or whether it is something else on a TCD. And learning curve on TCD is pretty much easier. Whereas with TCCD, uh, we get to insulate the MCA very quickly, but the problem starts beyond once we start going beyond it. Let's say we want to go to M2 segment or the terminal branches of the MCA, or let's say the terminal branches of AC, or I want to see an ACOM. So these things are even difficult with TCCD as well. So the learning curve does get steeper once you go with arterial system towards the venous system. But whereas with TCD, I feel the learning curve is pretty much straightforward.
Okay, but yeah, this requires some expertise in doing it.
Yes, ma'am. And even the angle correction, I can still make an angle correction. Let's say my MCA is slightly tortuous, or let's say my ACA is tortuous, or my PCA is arising from the ICA itself. So I can make the correction of angle correction looking at the vessel itself. But you won't be able to make that angle correction to measure the appropriate velocities with TCD. Certain authors do say that you need not corroborate with the angle correction with respect to intracranial compartment with TCD, because most of the TCD, there is extensive literature on the TCD, to be honest, so that you have a set values of velocities for each of MCA, ACA, and PCA, so on and so forth. Whereas with TCCD, you need to make certain angle corrections to arrive at an appropriate velocity for that vessel. So that's what makes it slightly difficult with TCCD sometimes. Sometimes you'll not know whether the velocity I measured is normal, or is it slightly higher up, or is it abnormal. So you might be in doubt once you make that angle correction.
Okay,
The
Dr.
next
Pramod.
question,
Yeah.
yeah, but can we
No,
do
no.
TCCD without precision? Uh, so Dr. Bharat has asked, can we do TCCD without a TCCD preset in USC machine? Uh, I think Dr. Shweta Shri ma'am would probably like to answer this if she can. Any disparities between TCD and TCD? Dr. Rohini has asked, any disparities between TCD and TCCD flow velocities and indices? So there is absolutely no disparities with indices, because indices is always derived with the velocities which are measured. So it depends on how you're measuring the velocity in TCCD. TCCD is more of you have a control of measuring each and every velocity, whereas TCD it's just the angle of intonation. You tilt it, you get a good waveform and you get the velocity. It's as easy as that. So there is an extensive literature on the TCD which gives appropriate values for each of a good range of values for each of the vessels. So that makes it even more robust when you're using TCD. Whereas with TCCD, the flow velocities are still within the range. But as I said, if your angle of intonation, or if your angle is somewhere in between, or if it is more than 60-degree, you get a very erroneous value. So that needs to be kept in mind when we speak of disparity between TCD and TCCD flows and indices. Indices will be same, more or less. What is the angle correction in TCD? So you have a window of pulse wave, a pulse wave. When you're measuring the pulse wave Doppler, you get a sample volume gate. So you have a cursor in between. Let's say there'll be two parallel lines. So you have a cursor in between. That is the one which measures the angle of your probe with that of the flow of your blood vessel. So suppose, let's say your blood vessel is this and your angle is this. So you keep the cursor, that is the angle between, it's same as and parallel to the vessel. And suppose, let's say this is your vessel and your angle of cursor, which I mean to say, is like this. So this is absolutely an direction which is not in the direction of the flow. So you can correct. Most of the newer ultrasound have an autocorrect option wherein you just press autocorrect. It does correct the angle to in between the vessel so that it measures the appropriate vessel velocities. In case if it doesn't do it, you can manually tilt the angle. There will be an angle correction bar. When you press the angle correction bar, it can take you from different degrees so that the cursor between the sample volume gate tilts towards the appropriate angle. So you can try that, measure the velocity in different angles and see what exactly you get. I think Dr. Shweta can answer this. Can we use TCCD without a TCCD preset in ultrasound machine?
Ideally, we require actually a TCCD software in situ. However, if that software is not there, we can still be doing it on a cardiac preset. Of course, it's not an ideal situation, provided the harmonic imaging is totally turned off. Wherein ideally the harmonic imaging is on. The whole purpose is to delineate the deeper structures and the grayscale. But once that is turned off, along with the increase in the penetrance, still we should be able to insonate the basal vessels. So we can still do it, but we require these alterations. The harmonic imaging has to be turned off, and probably we'll have to increase the penetrance, and then we'll be able to insunate the blood vessels. Yeah.
Thank you, ma'am.
But of course, ideal is always, we have a TCCD software in C2. That is always an
Yes.
ideal thing where you can, yeah.
So
But
the latest machines, in fact, uh, uh, to the latest softwares and the machines in the market, which I have recently used when I was in Italy for a fellowship, will have a preset for your transcranial arterial system, transcranial venous system, and orbital system. So as soon as you press that, the venous system, the all the settings which will help you to visualize a vein better will be automatically adjusted by the system itself. All that you need to do is get a good window. So things are advanced so much that it's quite easier these days, probably with the advanced machines. Probably going forward, we do even get the velocities and the literature from the TCCD as well, with the robust evidence going forward.
yeah, and also these presets can be actually created earlier itself,
Yes.
like the way Dr.
Yes.
Pramod said, like the arterial, the venous, or probably even the neck vessels. The presets can be created so that it can be easily used instead of adjusting all our filters and all by the time of we doing it. So if the preset
Yes.
is created within a few seconds, we should be able to insunate the vessels. Yeah. I think there are no further questions. So I would congratulate Dr. Pramod for the extensive presentation again. And
Thank
also
you,
I would
ma'am.
like
Thank
to
you so much.
thank NCSI webinar series for this opportunity. Thank you, Dr. Randeep.
At the end, I will just ask Dr. Pramod just one last
Yes, sir.
question.
Yes, sir.
Uh,
Go ahead.
how frequently do you do DCCD in your place?
So we do it routinely on most of the patients. Just to be honest, uh, it does not matter at times. Sometimes we do it for the practice, because it has a very steep learning curve. You don't want to unlearn what you have learned. So even if you know that the patient is normal, does not have any symptoms, or let's say a GB syndrome patient, I still want to just look at his internal carotid, external carotid, and it's we do it routinely for all the patients who require it. But even if when a patient doesn't require it, it takes hardly 5 to 10 minutes to just scan a patient in an ICU. So most of these videos which I have shown as well is in sitting position, wherein somebody is sitting and then I'm doing it. But in an ideal scenario, it has to be in a lying down comfortable position with a headrest or a pillow, and the patient resting comfortably, because that makes a lot of difference, a comfortable patient. And in ICU there are so many things around. You have a ventilator, you have a central line catheter, and so many things. So there are certain limitations physically when you use it bedside, especially in the neuro ICU. So you might have to train yourself using both your hands. Let's say you're a right-handed or left-handed, you're doing it on the right side of the patient and left side of the patient, because of the space constraints as well. So as you do more and more, you learn more and more. You learn your own technique. You make your own technique, and probably going forward, it will help you to streamline things and hopefully use it on most of the patients. Routinely, we use it on all the patients who require it, like stroke patients, aneurysmal patients, and be it infarct or be it bleed. Sometimes we see the resolution of the bleed. Sometimes we see the vasospasms. Sometimes we diagnose the flow reversals on the brain dead. So we use it routinely in the ICU.
So, Sudarshan ma'am, since I'm not seeing any more questions, so shall we end the session?
Yes, yes, Dr. Randeep. Yeah.
I would like to
Thank you
extend
so
thanks
much.
to thanks to Pramod for a wonderful and elaborate session on neurosonology and including neuroanatomy, and Sudarshan ma'am for moderation. I bring this session to an end. Thank you all.
Thank you.
Thank you. Thank you all.